You may heard earlier from Adam Pertman that the Commission to Eliminate Child Abuse and Neglect Fatalities released its final report in March. And I was a member of that commission. And so usually a moderator doesn't actually present anything, he just introduces the people on the panel. But I've been asked by Daniel, given the report and its focus on interoperability and data sharing, to give a little bit of background on the commission and talk about the key recommendations that are related to this topic. So just as a little bit of background, the commission was created by the Protect Our Kids Act of 2012. And it was charged with developing a set of national recommendations, not just to reduce the number of child fatalities due to abuse and neglect, but to eliminate them. Now, most people looked at that charge and said, that's impossible, that's never going to happen. But our charge was very similar to what happened in the airline industry about 30 years ago, where there were crashes and people just accepted there's a certain level of risk in airplane travel and that there would be a certain number of crashes, hopefully a very small number, but there was a level of risk we were willing to accept. The charge of this commission, it was really reflected in the total change in the way the airline industry saw itself. It didn't say we're going to try to limit the number of crashes. It says we're going to eliminate them. And they changed the way they approached the entire task. And for someone who gets on planes 4 or 5 times a week, I'm really glad that 30 years ago they changed to that perspective. But that was our charge. And there were 12 commissioners appointed by the President and the Congress. We held hearings for about 11 hearings around the country over 2 years and came up with some key findings. First of all, just to dramatize the issue or make it real, 4 to 8 children die every day from child abuse and neglect. So we as a commission woke up every day knowing that 4 to 8 children died that day and will die the next day. And so it motivated us to take a really hard look at this problem. We also found that half of the children who died were less than a year old, and 3/4 were less than 3 years of age. But the most striking thing to me and to many of the commissioners was only about half the children who died because of abuse and neglect were known to Child Protective Services or the child welfare field prior to their death. But they were known to somebody. And what was striking is that they were known to either criminal justice, juvenile justice, health, public health. Some system had come in contact with the family and knew something about that child, and often knew that child was at risk of something. And yet, the data sharing, the information sharing wasn't there. And so while the commission had a number of important recommendations, we recommended that, for example, that CPS would see a significant increase in funding. Some of us believed it should go to about $1 billion a year. We also recommended sort of expedited screening processes and investigation for kids under the age of 3 who are reported to be suspected of being victims of abuse and neglect. But most germane to this topic were the recommendations regarding increasing data sharing and interoperability. And so the report itself was structured around challenges and recommendations. So the challenge around interoperability was this: when agencies do not share data about children and families at risk, children die. Now that's a hard statement to hear. But this is not just an academic exercise. I know I'm talking to a lot of people here who work in the child welfare field. But this is literally a matter of life and death for children. We don't have a whole lot of time to get this perfect. We just got to start to actually make it happen. And so from that challenge came recommendations broken down by what the executive branch should do, what the Congress should do, and what states should do. And I'll mention these briefly. I hope there are still some feds around. I'm a former fed myself. For the executive branch, we recommended that there be a special initiative to support real-time electronic information sharing regarding children and families, and that HHS in particular should issue regulations that require that state entities share real-time electronic information, particularly around those agencies most likely or systems to come in contact with kids: law enforcement, CPS, public health agencies, hospitals and doctors, schools, and early childhood centers. We also recommended that the executive branch should do a better job of sharing information within the executive branch, not just about telling states to do it, but them to do it. There are lots of data sources within the federal government, lots within HHS, and they don't do a good job of sharing information with each other. So our second recommendation was to increase the interoperability of data sharing across federal systems. And then we went to the Congress, and we said Congress should do two things. It should consider what legislative or funding changes should be required to empower the executive branch to do the things we just said they should do. So if there's laws that prevent it, change the laws. If they may need money to do it, give them the money. And then the second thing we recommended for Congress was that they look at the privacy laws and pass legislation where necessary to make it more permissible to share data involving children and families involved, particularly in the child welfare system. And then finally, we said for states and counties, there should be a requirement for at least cross-notification of allegations of abuse and neglect between law enforcement and CPS. So there's a lot in the report, but it was a major, major focus of what it is that we thought the country needed to do to eliminate child abuse and neglect fatalities. And again, I started out by praising Daniel, but Daniel, I think without you, the symposium, the work that you have generated around the country, I'm not so sure that we have had as strong a recommendations we had, so thank you again. So at this point, I'm going to turn the podium over to two people who I just think the world of, who are not just thinking about these issues, they're doing something about it. And you've got the bios in your sheet, but let me just mention quickly, the first speaker will be Nick Lyon, who is the director of the Michigan Department of Health and Human Services. He comes with many, many years of experience. When Governor Snyder decided to merge human services and health, what a concept, merging health and human services together, he said, the one person in my state who's most qualified to do that is Nick Lyon. And then the second speaker is going to be Sean Pearson, who's the Deputy Cabinet Secretary of the New Mexico Human Services Department. He also previously was the CIO of the New Mexico Human Services Department, and he has done an enormous amount of thinking around how you actually implement the technology assets to get to interoperability. So I'll turn it over to Nick.
I have a prop. I need a volunteer. Somebody's willing to walk. Somebody. Do this for me carefully because it's come apart a couple of times. Just hold that in. Just start walking with that backwards. Just have to get it proper. Thank you. I'm good. Thank you. So what you have there is our application for assistance that somebody has to go through when they walk into our office. It's long, right? I think it's about 70 pages. And I am not kidding. On page 14, we actually asked the question for each of your children you're applying for benefits for, what was your child's conception date and place? What are we doing, right? What are we doing in health and human services? This is the types of stuff that we are asking people to do. Now, I want you to take a step back for a second. I visited a place called Sevilla in southeast Michigan, and they actually put us in a room, handed us that application and paper, and then put us in a chair with some other people who were pretending to fill out the application, and then had background sounds of what a DHHS office would sound like, a health and human service office in our state, but a local human service office in the other states sounds like. And I was trying to, empathize with somebody that walks into that environment for the first time on what very could be the worst day of their life, and then this is what they're faced with. And we wonder why our services are so hard to access, why they may not lead to the successes that some of our policymakers think that they should lead to. So that's sort of a starting point of what I'm going to talk about. Why does it look that way? In my mind, I think this is a big part of it, right? I know you cannot read anything on there, but what I tell you is this is a chart that the Congressional Research Services did for the House Ways and Means Committee as part of a committee they had that looked at really consolidating or looking at coordinating is a better word, Health and Human Services across the nation. And what you have is light blue is food aid, gray is energy, orange is health, light green is cash aid, et cetera. But these are what Secretary Hazel referred to as our cylinders of excellence at the federal level. Each with their own set of rules, each with their own set of stakeholders, each with their own set of individuals who are going to look out for the best interests of their program and potentially their bureaucracy rather than the person that they're supposed to serve. They're good-intentioned programs, right? Good-intentioned people running them. But what we've done to people is we've actually forced them into a system that parses them by program rather than looking at the person as a whole. So what did we do? Wade mentioned it. About a year into my being named the director of the Department of Community Health, which at that point in time had public health, behavioral health, substance abuse, and Medicaid, so it wasn't a small department by any means. Part of what he decided he wanted to look at was potentially consolidating all of those programs that served those who had a health or human services need. He felt that there was a link between the two. So at that point in time, we talked about some of the successes we had and whether or not it might be possible. And the two things that he pointed at was something that we called Pathways for Potential, which is where we have what we call success coaches in schools. We placed human service eligibility workers into elementary schools to begin working with families. And if you can build up the trust that they're working with your elementary school child, you can begin to build up the trust that you can work with the family on a variety of benefits that they may need. So he merged the departments. I've been at it for a while now. We're no less guilty of having many programs. If you look there, that's a list of the programs that's in my department in the state of Michigan. $24.8 billion gross, $4.3 billion of state general fund, general purpose revenues. It represents about 50% of the entire state budget, and that includes colleges, universities, corrections, et cetera. So it's a big department. We serve more than 2 million people in food assistance programs, our version of FAP, the SNAP federally, and 1.7 million people on traditional Medicaid and 600,000 people in the Healthy Michigan Plan. And it was the success of the way we implemented the Healthy Michigan Plan, the fact that we were able to get it up very quickly, maybe one of the quickest implementations of a major healthcare program in the state of, well, certainly in the state of Michigan ever. We had a very quick, we had a late acting legislature with a very quick deadline, and a governor who insists that we work in dog years, right? We heard that comment earlier, and he means it. So we got it up and running, and those sort of things built on this concept that we could succeed and we could be more integrated, I think is the best word. So our next iteration of this is what we call integrated services delivery. And today, it's kind of like I said, we have a program focus. We're focusing on, how do you qualify for a program? And what we're really looking to do is how can we make these programs more holistic? That when somebody comes in the door, we're not saying, what do you qualify for? But we're actually talking to the person and saying, what are your needs today? Where do you believe that you're falling short? What do you need to be successful? What do you need to be employable? What do you need to help in the care of your children? So what we've really looking at trying to do in the future is build a success coaching model rather than the caseworker model. And we know that it can't just be government-based, it has to be community-based as well. Person-focused, and our goal is to provide well-rounded, localized, and targeted support to maximize results. The key components of it is an integrated services delivery portal. This would be over the top of the many programs, automated programs we have today, including our child welfare system, our eligibility system for all the programs, that thing, and our CHAMPS program, which is our MMIS information. These would have person-centric models. Universal caseload management is very important. You go back to that first chart I showed with all the bubbles on it, or you go back and look at our programs, you think about how hard it is for us to navigate. I've been in it for 15 years, and I can tell you the complexity at times still surprises me. There's things I see every couple of weeks or really think, what are we doing, right? Think about how hard it is for our caseworkers to navigate, right? Caseworkers are trying to figure out the different programs. Policy changes happen, federal law changes, state legislature does something, maybe they put in an asset test, maybe they increase it, maybe they remove a program, we add a program, whatever it may be. It takes months to get to the caseworker. And you think about how difficult that is for the person. So our goal is, how do we make it better for the person? And that's nearly impossible to do when you have caseloads that in our state on the assistance side can be 500 to 800 per caseworker, right? So how much attention are you going to give a person when you have 650 families you're dealing with? So part of what we're trying to do too is, how can we separate the work in a way that we have customer support people who are more centralized that can take some of the first line calls, and we can get our caseworkers back to doing what they want to do, which is being caseworkers. Another thing we got going, which really fits into this, is the Blueprint for Health. This is Michigan State Innovation Model Grant, and this was pre-merger community health activity. We were a design state. We won an implementation grant, and it builds upon having patient-centered medical homes, accountable systems of care. We had a couple of successful pioneer ACOs. I'm not sure they continued down that route, but they we were certainly building on those sort of shared saving models and having solid patient-centered medical home incentives that helped provide better care that we talked about today, that tries to get to some of the social determinants of health. One of the things we're hoping to build out of this is community health innovation regions, and that's really having something in place where we're getting back either through community workers, community health workers, back through local providers, volunteer agencies, community service agencies that can really help us on the ground, help people address the needs that they have, whether it's transportation, housing, things of that nature. Safety of the streets, things that we're all talking about that affect people's health. Why do we think we can do this? We can do this for two reasons. We have a governor that strongly supports enterprise information management, and he believes that this is a possibility. This is what we need to do going forward to best utilize these federal programs in the way it helps people going forward. And what that has led to is an environment where we work very closely with our health information exchange and our health information technology, and we've been able to build upon the successes that we've had in the past to make them think this can actually work. I'm on the right slide. So these are some of the things we've done. Care Connect 360. It's a view of a person's medical history that we're now sharing from our Medicaid health plans to what we call our Medicaid prepaid inpatient health plans. So it's the behavioral health Medicaid providers getting the information that the primary care provider could see. We've also begun using this and sharing it with our child welfare agencies so that if children come in the door, we can know if they have a history of asthma. Have they seen a behavioral health specialist? Have they seen a dentist? Have they seen a primary care physician? Michigan Care Improvement Registry, this started out as a childhood immunization registry, but we've been putting much more medical history into that. Pathways I talked about, and then some other things as well. I would say that we have a very strong health information network in our state. They're forward-thinking. They have standardized many of the things that we're trying to do around consent and the regulatory requirements that we have. And certainly they're part of the success that we have in the interoperability as well. So with that, I want to say thank you for allowing me to speak here today, and I'll turn it over to Sean.
So good afternoon, everyone. As Wade mentioned, my name is Sean Pearson. I'm with the New Mexico Human Services Department, and unfortunately with the previous presentation, we're, I think, one of the few states that was all red for the opioid issues that we're facing in the state, but it kind of ties well to what we're doing in New Mexico. So just to provide you a little bit of background, we're a very small state population-wise, a little over 2 million, but large geographically. We're the 5th largest state in the country from a landmass perspective. We have over 860,000 New Mexicans today that are on Medicaid. We're approaching 50% of our population on Medicaid. Over a quarter of our population is on the SNAP program, and we just go on and on there from our human services programs. Our state general fund budget is a little over $6 billion, and we're spending almost $7 billion when you combine the federal dollars on human services programs to include Medicaid within our state. So it's a substantial piece of what we're doing in New Mexico. A few years ago, we were fortunate to implement a new integrated eligibility system that provided us greater information for the first time. We've had integrated eligibility systems in the past, but we weren't using them in an integrated way. And one of the things that we were able to see with this new system is that many of the recipients we had on our programs were on more than one public assistance program. And so what you see on the slide up here is that, for example, in TANF, 99% of our TANF recipients are on another public assistance program within our state. And that's just the programs that we manage within our agency. It gets even higher when you start to look across some of our sister agencies. We manage Medicaid, TANF, SNAP, behavioral health, LIHEAP, et cetera. We don't manage child care, and we don't manage WIC within our agency. Overall, when you look across, we have about 900,000 unique New Mexicans that we're supporting in these programs alone. 70% of them are on more than one public assistance program. So we're very fond of what we've done from an integration perspective, but we've primarily been looking at it from a back-end perspective. And we lost visibility of thinking about who do we serve within our state and what are we doing to make it easier for them to be able to apply for benefits, get information about their cases, et cetera. So we were probably one of the last states that actually launched a portal for applying for benefits. We launched our portal on October 1st, 2013. But it became one of many portals that people access when they wanted to apply for benefits and services. And we made it very confusing for those recipients to understand, applicants to understand where did they go when they need help, when they need those services. And we've been working hard to integrate, like I said, on the back end with our Medicaid program. We integrated long-term care services, behavioral health services, and physical health services. But when we did that, all we did was just put up another portal. And we're heavily managed care within the state. We have 4 statewide managed care organizations. About 90% of our Medicaid population is enrolled in Medicaid managed care. But each one of those MCOs launched their own portal as well. So the problem became more and more problematic for those that we served, the more and more programs that we rolled out, because every program came with a new portal, a new entry point for those that we served. It also became very confusing for who do you call when you need help. And alone, just within our department alone, we operate 12 different call center functions. 3 of those are for Medicaid. So who do I call when I have a Medicaid question? And that really depends. Are you applying for Medicaid for the first time? Do you already have Medicaid? Do you have an issue with the Medicaid benefits? It becomes very confusing. We're not too dissimilar from Michigan in that our application may be a few pages shorter when you combine all of it, but we have multiple applications for benefits and services. We implemented an integrated benefit application, but the more and more that you start to add new services, new programs to Medicaid, to TANF, to SNAP, et cetera, the longer that gets. And we don't deduplicate some of the information gathering requirements that we have. The other challenge for us in New Mexico is I feel like we have this kind of rinse and repeat cycle for how we administer and manage these public assistance programs. So if you think about it, we give a person a piece of paper or a website and we say, check the box for the assistance program that you're applying for. They check that box, we go through the eligibility process. If they're determined eligible, they're enrolled in that program, and then they repeat that process on some regular basis, 6, 12 months, whatever the requirements are. At no point during that process do we actually sit down and take a look to see if those public assistance programs are addressing the barriers that those individuals have to becoming self-sufficient. Our agency, in our mission statement, is to reduce the impact of poverty on folks to help them become self-sufficient. But we're not doing any of that today. So we have a ton of work that we can do. Tomorrow, in the form of 2020, we know that over 50% of the people in New Mexico are going to be on a public assistance program, and that's a problem for us. So we developed what we call our Health and Human Services, or HHS 2020 initiative, which we consider to be the roadmap to the future of health and human services in New Mexico. It focuses on kind of 3 key areas. First and foremost, putting the person first. So you heard this from Nick, and you've heard this from other presenters today, but we can't lose sight of who we are there to serve and support and help within our state. And so anything that we do needs to focus on the person first. We always need to make sure that we're improving outcomes for those that we serve, so making sure that we're measuring what it is we're doing today, what are the benefits and services that we're providing today, how well they're working, and whether or not we're improving upon those, as well as the people that we serve. And then last, reduce, reuse, recycle. So I mentioned that we spend over our state general fund equivalent in managing health and human services programs within New Mexico, but a very small percentage of that, about 1.75%, actually goes to administration. We're not going to get more money towards administering these programs. Very rarely does anyone want to increase the amount of money that goes towards that. They want to see more of those dollars go direct into services as opposed to the administration. So all three of these things are key for us across the Health and Human Services enterprise, which exists outside of my agency's walls, but with some of my sister agencies, as well as some federal partners, and then some of the community partners that we have. And so we've developed this sort of diagram to kind of illustrate what this means for us. And this is something I use internal to our agency, and then it gets much larger than what I'm able to display here on the screen. But if you think of very much what we've been talking today with the social determinants of health, and what we're looking at, in this diagram in particular with food, employment, health, and shelter, the second ring matches up the programs that I have within my agency that help to address some of those determinants. When you start to go outside of agency walls, whether it's other sister agencies we have in our state or community organizations or federal partners, that gets much larger with those services that we have to offer. But at no point do we start to really look at how we align those services to better support New Mexicans and what their barriers are to becoming self-sufficient. Typically what we do is we give someone a piece of paper and say, here are a list of community resources for you, or maybe we do an electronic referral to another organization. But that's about all we do within our state, and that's something that we really have to improve upon. So around engagement, what we're moving towards is a one-stop shop, and not just a virtual one-stop shop where people can go online to a website or through a mobile device and access the information for benefits and services are available to them, but actually allow them to be able to engage, to apply for those benefits and services, to be able to interact with that organization, no matter if it's my agency or another agency, to be able to manage their cases that they have, and also move to one call. As I mentioned before, we have 12 different call center operations in our state. We could do a much better job than what we're doing today. And then lastly, move into a brick and mortar one-stop shop. So we operate about 40 field offices across the state. When you start to add some of our sister agencies, we have over 150 field offices throughout New Mexico to serve, population about 1 million recipients currently. It doesn't make a lot of sense the way that that's working today. So what happens, for example, is we have a applicant who needs help with child care services. We literally give them a piece of paper, and we say, go down the street, here's the address for the Children, Youth, and Families Department. And many times what happens is they're never seen. They never walk through those doors of the Children, Youth, and Families Department. It even gets worse within my agency. We operate those 40 field offices, and in several of them, we have our child support enforcement division that's responsible for ensuring collections of child support from non-custodial parents. And so if I have a TANF mom who comes in, who ends up on the program, we give her a packet and says, here's your cooperation packet, and I want you to go down the hall to our child support folks and fill out this packet of information, which is the same information I've already collected from you to help determine your TANF eligibility, and so that you can cooperate with child support to ensure that you can continue to receive your TANF benefits. It's an extremely ridiculous process. Many times those individuals have already spent several hours probably waiting in our lobby so they can speak to one of our caseworkers, and they don't have time to do that. They need to get back to whatever they were doing, whether it's their place of employment, whether it was childcare, whatever they were dealing with. Instead, what they do is they walk out the door with that packet, and we never see them again. So I've heard several times today mentioned that technology is the easy part, and frankly, it is, in my opinion. As Wade mentioned, I was the CIO at the organization for years before this current role, and CIO at some other state agencies. And the technologists will love to tell you how difficult it is to make themselves seem glorious in what they do, and it's magic, but it's not difficult. What you see on the screen here is what we call our Health and Human Services 2020 Enterprise Framework. And largely what we're doing is we're implementing this framework primarily through the enhanced Medicaid match that we have with the 90% funds and the cost allocation exception that exists through the end of calendar year 2018. And we have 2 system replacement projects that are ongoing right now. One is replacing our Medicaid management information system, and one is replacing our child support enforcement system. And they're going to fit into this framework. And while they may be disparate applications and systems that we will always have, whether they're cylinders of excellence from a program perspective, we're going to have some of those cylinders of excellence from an IT perspective, we expect that they're going to plug into this framework so that we can greatly enhance how we share information among these disparate systems and services. And what we're going to do with this is also change the way that we engage people that we serve in the state and change the way that we leverage data and turn that into useful information for managing our programs. So my agency alone, I have 4 data warehouses. I have 5 different analytics tools, and I have dozens of economists and data geeks and everyone else that analyze that data on a regular basis. And we still struggle answering basic questions. It's a problem for us, as well it is probably for many of other states within the country. So we're very excited about this framework. We're able to capitalize on the enhanced match to really benefit our other human services programs. And a lot of times what I'll do is when I talk to other organizations in particular, I try to get them to understand that Medicaid is your friend. Usually they're kind of the 800-pound gorilla in the room that no one wants to talk to, but it can't be a middle school dance for you. You have to go across the gym, go across the aisle and speak out or speak with them to really tap into those enhanced dollars. And I think the feds have done a really good job of trying to carry that message to not just within Medicaid agencies, but outside of Medicaid agencies. An example of this is something that I use when I talk with some of our sister agencies and other partners, because a lot of times what happens is I get pushback from them to say, this is my program, I own this program, I own this system, I own this data. And I'll pick on WIC, for example, just because they're a recent example, where even with our federal partners that we talk to at WIC, which is part of Food and Nutrition Services, which is part of USDA, we struggle with getting them to understand that there's a lot of opportunity to capitalize on investments that already been made, whether they're eligibility systems that we've implemented or other states have implemented, or future investments that are going to be made to benefit that program. And instead what happens is they're moving forward with their own system replacement. They're going to spend $80 to $120 million replacing their systems when we've already made that significant investment. And there's a lot of technology that could be leveraged for them to benefit them because they're serving the same people that we're serving within our programs. So what we've changed the conversation to for some of our partners is that let's build components and services that can be leveraged to benefit more than just our agency or more than our systems, and still allow them to maintain the ownership and autonomy of their programs and systems, and then strengthen the way that we communicate with each other. So you see at the bottom of the slide is a reference to NEAM, which is the National Information Exchange Model, and there's different domains associated with NEAM. And so a lot of what we do in New Mexico is talking about those domains and how we share information, but not in such a way where I'm taking a massive data set that I may have in the Medicaid program and shipping it over to the WIC program and vice versa, because we just complicate the problem. And pretty soon what happens is our data sharing diagrams start to look like electrical wiring diagrams, and we spend all our time trying to deduplicate and deal with exceptions that exist between the systems. And that's what I have. Thank you.
So we have a little bit of time for questions, so I think we may need a mic up here, and then Elena?
Can you hear me? Do I need a mic?
You don't need a microphone.
Okay, great. So first of all, it was a fantastic presentation, so really excited to hear all the work that you're doing. I was wondering if you could talk a little bit more about the culture change, and this is for both, that you'd have to do within your agencies to get your sister agencies to understand the benefits of collaboration, but even within your own agencies to get your folks in this new mindset.
I think for me, it's sort of interesting because we dealt with culture change post-reorganization. When you came from the health perspective, we contracted with PIHPs, we contracted with HMOs, we contracted with public health departments, we contracted with the area agencies on aging, we contracted, we had the WIC contracts through local public health, et cetera. DHS, the human services side, was frontline people in all 83 counties in the state working with people who walked in the door. So I think trying to merge those cultures was a very interesting thing. And that's actually, once you realize that the common goal is the same, that worked pretty well. So that's been my challenge. So it's not like I don't have a lot of sister agencies that I have to deal with in these programs because of the reorganization, but it is interesting when I go to like MSP or the court system, that can be a much tougher deal, and it's something that we're working on, and you just have to convince them, one person at a time, one group at a time, that if we can get out in front of these things, and this is something I'll say pretty quickly, we get out in front of those things, we'll do a much better job. You know, in the health side, for years and years and years, we've learned that prevention is very important. What we do in our 20s, 30s, 40s, and 50s is going to affect our quality of life in our 60s and 70s, et cetera. And you got to take that prevention framework and really apply it, especially in the child welfare side. I think that's one of those case studies that I think we really have to push towards. All of us need to push for it. You know, we're so reactive when something bad happens, but if you can use analytics, share your data across your organization in a way that makes sense, the way that meets the laws, and you can begin to identify at-risk families for abuse, you can really save not only the system a lot of money and effort, right? No interaction with a child welfare specialist, no interaction with a police officer, no interaction with a court, no interaction with a foster care agency, and if it was bad enough, no interaction with an adoption agency. If you get ahead with just some preventive services that teach something like parental resilience. And quite frankly, you know, I didn't know what parental resilience was until my kids turned about 13 and 11, right? So 13-year-old boy, 11-year-old girl. But, you know, those are the types of skills that you know, parents might not be able to acquire or have based upon their own history. And I think, what can we do to help them get those services that they need? They have those supports. And if you do, you've saved the system a lot of money and time. You've saved those parents a lot of anguish, and you've saved the child a whole bunch of adverse childhood events that could impact their behavioral health and physical health in the future.
So for New Mexico, organizational change management's been key to what we've done. And there are two examples I can give you. One, I joke that our Medicaid program didn't know that anyone else existed within the agency until around late fall of 2013. And the reason for that is we were one of the states that expanded Medicaid. We did a full expansion to 138% of the federal poverty level. And it resulted in a flood of referrals to our child support enforcement program. And they started screaming because their obligated case percentage started tanking. And they were worried about what that meant for their federal performance measures, incentive dollars, and it just became this domino effect within our agency that we took all of our leadership within the room and said, this isn't working anymore, guys. We've got to change the way that we operate, the way we talk to each other, the way we do business. And so we formed that governance at that level, which has helped. The second thing that we do is anytime we have a new initiative, whether it's an IT-related initiative and project or a new program or whatever, we always create kind of a change agency or change agent network where we empower individuals in our field offices primarily who become those change agents who are a communications channel as well for us to understand what's going on in the local field office, what can we do better support them, get some feedback on how well things are going, so on and so forth. And that's been extremely successful for us in New Mexico.
When I was in the federal government, we used to say the definition of collaboration between federal agencies was an unnatural act between non-consenting adults. I hope it's gotten better since then. But other questions?
I have a question about NEEM, and excited to see that you picked it up. I was curious where that came from and how that's permeated your organization.
Part of it came from, prior to my role at Human Services Department, I did a lot of work in health IT and was our state health IT coordinator for a while and ran into all kinds of challenges with just exchanging information for clinical use and other purposes and trying to promote that within our state. And so when I came over to the human services side, I ran into NEEM through Joe Bodmer, who worked in ACF with the Office of Child Support Enforcement. Never really heard about it that much until then. And so I became a fan of it and began working with that, with his agency and organization to understand how that applies to us. And then what we did in New Mexico is we created kind of a harmonized framework for leveraging MITA, the Medicaid Information Technology Architecture, NISIA, which is the National Human Services Interoperability Architecture, and then NEEM for all of the information exchange. And I pick on our federal partners a lot. You know, I got two different architectures and frameworks from the same federal agency, but you know, how can we best leverage that and use that within our state? And what it really helped us to do is to have a conversation about the same things. So when I started talking with our child welfare folks who are in a separate agency, which is a program I don't really know much about, NEEM helped to bridge the gap to what they were talking about versus what we were talking about.
I don't know what the acronyms stand for, but I tell you what we've been able to do with our exchanges is we have master person index, and we're sharing the ADT data, admit, discharge, and transfer data through our health information exchanges, so that we're trying to make a real use case for getting the information out to the providers as quickly as possible. And again, if we get it in the child welfare system, all the better.
We have one question over here, one last question.
How far along are you each in the actual automation, interoperability, and also with the business processes and culture?
I think with our interoperability, I mean, we have, it's an ownership thing, right? But we built our Medicaid data warehouse, and then we have just, it's like he said, I came from the Medicaid program in a lot of ways. That was what I learned first when it came to this. So it is a good funding source. And you have federal agencies right now who are very interested in interoperability. Murray Kanchan, who was on that film, and Jessica Kahn, who was supposed to be on that film as well, have both been very supportive of Michigan's efforts in trying to really be more interoperable and be more interoperable friendly from the federal level. All that said, I think we had a data warehouse that we shared lots of information with our housing agency, with our justice areas. It's about how do you take those, and rather than being, the data gets dumped in and it's being pulled back out, how can we make it real time? And we have some, the ADTs through the Health Information Exchange is about as close to real time as you're going to get, and we have some examples of that. But with our Care Connect 360 program, but we got a ways to go.
So we have over 100 different interface partners that we share data with, both inbound and outbound. So I'd say we're pretty interoperable from that perspective. It's definitely not a technology issue. I think in some areas where you have the analysis paralysis going on, where there's so much data that's made available, we really don't know how to use it. And what we found is we're struggling with what are the questions we even ask, and then what are the data we have available to help answer that. So I think interoperability is not so much a challenge for us in New Mexico behind the scenes. It's a challenge for us in the public face and how we engage those New Mexicans that apply for our benefits and services and things like that.
So the purpose of this panel was to demonstrate something that 5 years ago we really couldn't have had a panel on, which is that there are state government leaders who are not just thinking about interoperability and data sharing and how to actually make that real, but are doing it. There's others in this room we could have included on this panel. Secretary Hazel certainly could have been up here talking about the things he's doing as well. And it shows, we wanted to show just how far the field has come in a relatively short period of time. So join me in thanking our two panelists.